Hello. Today we will talk about the aerodynamic, which could be appear as a question in part 3 exam, and also it will help the people who are going to part 2 MRCOG exam. So the aerodynamic can appear in part 3 MRCOG exam as a teaching session or a simulated colleague task where your ST5 or where your ST3, your colleague, the junior doctor, come today asking to know more about the aerodynamic. So you may find the instruction outside as you are the ST5 and you are about to meet your junior doctor, the ST2 or ST3, who are asking you to explain for him the aerodynamics. There will be some diagrams and some picture to aid you during your session, and you are expected during the 10 minutes to explain the aerodynamic for you to your colleague, explain the indication and how it can be done, what is the component of the aerodynamic, and how your colleague can reach to the diagnosis. So, as in every case of the teaching, you introduce yourself and your role to your colleague without mentioning doctor or mister, only by your name, and confirm the name of your colleague. Make some report with your colleague. Check the purpose of the meeting today, and make sure that he is coming today to understand more about the aerodynamics and explore concern why your colleague come today wanted to know about the aerodynamic exactly. Check for any hidden agenda of undermining and check the background about the aerodynamics, whether he read any articles, he saw any videos about the aerodynamic and expectation, what he want to know from the meeting today. Uh, then put your agenda. Your agenda should include the what expected from you, which is written outside the cubicle. So if the indication is there, it should be included in your agenda. If the component is there, also it should be included in your agenda. And if the diagnosis is there, you should also include it in your agenda. So your agenda should include what expected from you outside the cubicle. Okay. At the end, post your colleague to some guideline to help him to read about or to know more about the aerodynamics, like any links or any videos or any websites. Uh, Please encourage your colleague to ask you and to stop you if he has any question about the aerodynamic today. Then the aerodynamic is a series of tests which conducted in the outpatient setting to evaluate the function of the bladder and the urethra in relation to the storing and releasing the urine. It means that the filling and voiding phase. And it composed of two parts, which is a uroflowmetry and cystometry. We will talk in detail about each one. Simple means it is not video or not ambulatory. What are the indication for the aerodynamic? You know that we do the aerodynamic to understand the patient symptoms like the incontinence frequency and the UTI. So the NICE recommend to do the aerodynamic after failure of the conservative and before we doing the surgery for the patient who has urinary incontinence. In certain situations, like if the patient have mixed incontinence and urge predominant, or the type is unclear. So in this situation, we can do the urodynamic. If the patient has urinary incontinence and symptoms suggestive of voiding dysfunction, if the patient has a urinary incontinence and at the same time has anterior or apical prolapse, or if the patient has urinary incontinence and he has a history of previous surgery to cease urinary incontinence. So before we're doing the aerodynamic and while the patient is on our clinic today, before sending it to the aerodynamic, we have to stop all the antimuscarinic medication. So ask the patient to stop the antimuscarinic medication before 2 weeks before the aerodynamics, like the sulfenacine, trospium, mirabirig. Also ask the patient to do bladder diary and give him the form to do it 3 days before the aerodynamic test. In the day of the urodynamic, we tested the urine of the patient, okay, by doing urine dipstick, and this to exclude any urinary tract infection. And if there is, we have to stop or to postpone the test for another day after treating the urinary tract infection. How we'll do the urodynamics? So the patient will uh, The idea of the urodynamic is to make a micturition cycle, like the bladder phase, filling phase, and voiding phase, while we recording the bladder pressure and the abdominal pressure. So the component of the urodynamic are two. The first component is the urofillometry. We ask the patient to sit on the accommodate chair like that, and to void, relax, and void. The urine is coming to the urofillometer, which is down under the chair. So in urine come to the urofillometer, it will be recorded by this machine, this machine, the rate and the volume. So the volume of the urine passed will be calculated on the machine, and the flow also, the rate of the flow is also calculated in the machine. The normal urofillometry is like that, like bell shaped with the maximum flow rate between 20 to 36. The maximum flow rate between 20 to 36. And normally the urofillometry is bell shaped like that. This is the amount of the urine voided by the patient today. After the patient do the urofillometry, we ask the patient to lie again on the chair, on the bed, sorry, and measure the post-voiding residual, either by doing a scan or by the in and out catheter. Normal, the post-voiding residual is less than 100. Okay, so if the patient has a more than that, she will have voiding dysfunction. The second part of the urodynamic is to do cystometry. In this part, we connect two catheter inside the patient. The patient is lying on the bed, and to put two catheter inside the patient. One inside the urethra to measure the vesical pressure, and one inside the rectum to measure the intra-abdominal pressure. Normally, there will be color different. So the inside the bladder may be blue and inside the rectum may be red or green. How we can calculate the detrusor pressure? The detrusor pressure is calculated by subtracting the vesical pressure from the abdominal pressure. So it will be the detrusor pressure. All of this pressure will be here on the monitor. All of these graphs will be here on the monitor. Okay. After connecting this catheter while the patient on the bed, we connect the um, catheter, the urethral catheter by water bag, which contain warm, sterile water. Then ask the patient to sit on the chair again and start filling. We start the filling by rate about 10 to 100. We can take average of 50 ml per minute. And while we are doing the filling, the pressure is recorded on the machine, and any leak during the filling will be recorded by the urofillometer down to the chair. During the filling, we ask the patient to declare the first sensation, the first desire, the strong desire, and the onset of any urgency. How we can say tell that to the patient? How that we can inform the patient or tell the patient to declare when she had the first sensation? So the first sensation, the moment when the patient feel that their bladder is no longer empty. If we imagine that the patient in the shopping center, and while she is doing shopping, she started to feel that she wanted to wee. This is the first sensation. First desire, when the patient need to go to the toilet without hurry. So while she is doing shopping, she started to look for the toilet. She started to look for the toilet without any hurry. The strong desire when the patient, without any pain or fear of losing urine, she wanted to void. So at that time, she will go to the nearest toilet. She will go to the nearest toilet. Feeling of urgency, the patient cannot postpone anymore. She need to do wee right now. Feeling of urgency or the maximum capacity okay, of the bladder. Normally it around 500 mils. When the urgency is reported by the patient is no longer can hold any urine inside the bladder. We will stop filling now and will ask the patient to do some action to provoke the leakage, like coughing, listening to running water, sometimes put her hand in a cold water, and any urine leak, it will be recorded by the urofilmeter. How we reach the diagnosis? With normal detrusor function, there will be no change in the detrusor pressure during the filling phase, despite any provocation. So during the filling phase, there will be no change in the detrusor pressure. If we imagine that the detrusor pressure and we fill the ladder, there will be no rise in the detrusor pressure at all. The aerodynamic stress incontinence, if we ask the patient to do any action which increase the intra-abdominal pressure, like cough, there will be increase in the vesical pressure, right? And increase in the abdominal pressure, increase in the abdominal pressure here, and increase in the vesical pressure, and there is leak, and there is leak. This is called urodynamic stress incontinence. The druser overactivity during the filling phase, the druser pressure will be increased, and this will lead to increase in the vesical pressure. Okay, sometimes it accompanied by leak and sometimes not accompanied by leak. But during the filling phase, there will be rise in the druser pressure like that. Rise in the druser pressure. This is a druser pressure. Okay, so there is a rise of the detrusor pressure and accompanied by rise on the physical pressure. Sometimes it could be some leak and sometimes no. This is called detrusor overactivity. If the patient has the symptoms of urgency or involuntary loss of the urine, but this not explained by the urodynamic, we call this sensory urge incontinence. Sensory urge incontinence. This is some numbers about the normal parameters and the normal reading of the urodynamic. At the end of the session, you can ask your colleague about the discussion today. Did he achieve his aim today? What was going well? What was not going well? How we can improve teaching to other and arrange another time to meet again and discuss anything he not understand. And that's it. Thank you.